All right, everyone, we're going to go ahead and get started.
Great. Hi, everyone. I'm Monisha Sharma, and I'm faculty in the Department of Global Health. And I'm excited to introduce Arden Saravis today to talk about dissemination of risk assessment information regarding respiratory infection risks in HIV departments to health facilities in Kenya. And Arden is a second-year MPH student, and she's worked on a number of projects ranging from qualitative studies to quantitative, which she'll talk about today with her COVID work, and also infectious disease modeling. And yeah, we're excited to hear from her. Thanks.
Thank you for the introduction. Hi, everyone. Thanks so much for coming and joining online. As Monisha mentioned, today I'm going to be speaking about the dissemination of risk assessment information regarding respiratory infection risk in HIV departments to health facilities in Kenya and Zambia, but with an emphasis on the Kenya data. So to start, I wanted to take us back to the early months of 2020 when SARS-CoV-2 first emerged and our world was figuring out how to best control its spread. Many decisions had to be made quickly, including impacts to HIV care by moving services to low-contact alternatives, replacing the high-contact standard. For some services, the effectiveness of this switch was not impacted, like for lower frequency resupply of ARTs from 1 month dispensing to 3 to 6 month dispensing. This actually benefited HIV treatment because this was an already existing intervention that was given the opportunity to scale up during COVID and has persisted since. But for some services, lower contact care methods were shown to be less effective than the high contact methods. This included in-person HIV testing, which was replaced with remote HIV testing, resulting in lower linkage to care. In-person ART adherence support was replaced with two-way SMS delivered support and led to lower rates of retention. And in-person psychotherapy for depression was replaced with teletherapy, resulting in lower treatment completion. Sub-Saharan Africa countries chose to implement lower contact versions of services because of the presumption that the benefits from reduced exposure to SARS-CoV-2 outweigh the harms of reduced HIV care effectiveness, but there was a lack of data to inform this presumption. Rigorous evaluation of the trade-offs of higher versus lower contact HIV services are vital to inform policy decisions regarding when and for whom higher contact services should remain. This can also be extended to other airborne infectious diseases and impact decision-making for HIV services given levels of community transmission of different diseases. So the first aim of this study seeks to determine the incremental effectiveness of higher versus lower contact HIV services in different populations and translates the effectiveness estimates, for example, engagement in care and viral load suppression, into health impact. The second aim, which is the focus of this presentation, determines the risk of airborne infections associated with higher contact versus lower contact HIV services. And the third aim looks at when and for whom lower contact services improve health. So the second aim will be incorporated as an input into the larger model by using risk calculations to estimate years of life lost and deaths due to COVID-19, TB, and influenza per patient using higher contact services and in total for each service. We'll then rank the services by transmission potential and years of life lost due to infections, and these aggregations will go into a larger model to quantify the health impact of high contact services. So today I'll be walking us through the analysis of the second aim and also speaking about a side project to disseminate this information to the individual facilities where the data was collected. So first, the primary research question for the second aim is, what is the probability that a patient accessing in-person HIV services would contract SARS-CoV-2 or another respiratory pathogen given different levels of community transmission? We conducted primary data collection at the facility level, and we collected non-patient data in clinical spaces that patients would access for HIV-related care. So we grouped these as different groupings of types of care. So the first one are CCC-ART patients who have been diagnosed with HIV and are there for standard treatment. Next, we have CCC active TB patients who are diagnosed patients who also have an active TB diagnosis. So will be treated for both over the course of their visit to the facility. We also have fast track clients that have suppressed viral loads, so are able to have an expedited visit to the facility and surpass viral load testing and adherence counseling. And last, we have HTS clients who test for HIV and receive a positive test and then are directly linked to care and initiate the treatment process. So we did representative sampling of around 120 facilities in Zambia and Kenya. Our data today will mostly focus on the data in Kenya, where we are set to sample from 59 total facilities in Kisumu, Siaya, Homa Bay, Migori, Nyamira, Kisii, Nairobi, and Mombasa County in a variety of facility types, including health dispensaries, health centers, county hospitals, and county referral hospitals. So next we'll get into the data collection process. There were 4 different elements to the data collection. So first, we have the room conditions data. This is the data that we collect in every single clinical space that a patient would go into over the course of their treatment. So in each room, we take a CO2 measurement in parts per million as a proxy for airflow, and I'll get more into the CO2 measurements in just a minute. We're also collecting the number of people in the space at the time of data collection, as well as how many people were masked or unmasked in the facility, and window and door openings to the outside, both if they exist and if they were open or closed during our collection. Next, we have time and motion data, where we record the amount of time patients spend in each space, and we also capture the typical flow of patients throughout the space. So what the data collection team does is observe patients from the time they enter the facility to the time they leave, and mark down the number of minutes that they're spending in each space. Next, we have the facility staff questions, where the data collection team sits down with a staff member at the facility and inquires about changes in crowding depending on the time of day, day of the week, and month of the year. And we're also able to capture physical variations to the space depending on the season. For example, if in some months the windows would be open but closed during others, or if an AC would be used if they have access to one. And then the last element of the data collection process is a time series CO2 collection, where the data collection teams leave CO2 monitors in a waiting room and a clinic room at each facility, and sit them in a place where they can stay for 3 to 5 days to collect data every minute. So we're able to see variations and fluctuations throughout a whole day or across several days to see for a sensitivity analysis. So next we'll go into greater detail about the CO2 measurement. One assumption that we make off the bat is that any CO2 inside the facility is coming solely from humans breathing. So we assume that there wouldn't be any animals or machines in the building that would produce CO2. The CO2 measurements are taken in all spaces that a patient will enter while accessing HIV care. A CO2 measurement is also taken 20 feet outside the facility to serve as a baseline or control measurement. And then we take the difference between the outdoor and indoor CO2 measurements to calculate an excess CO2 measurement, which serves as the indicator for airflow. So next I wanted to talk about the evolution of the data collection tools and some of the challenges that we encountered. So I was able to travel to Lusaka, Zambia to conduct pilot data collection. And Lusaka is an urban city, and we didn't have the time to go far enough outside of the city to see the true spectrum of health facilities that we would be testing from or collecting data from. So once the data collection team went to some of the more rural areas, there were differing infrastructures. So we had to make many modifications to data collection instruments. For example, these images here, the image to the left shows a waiting room space that is indoors. However, there is a wall that has perforation. So that's letting air flow freely through, and it didn't feel right to capture that as a window because it's significantly larger than what we would consider a window to be. So we ended up adding a check mark if there was a wall with perforations. And then the middle image shows what we've commonly seen as the waiting room space, which is an open corridor with the clinic rooms that are the doors there. So in these spaces, we are capturing this as a partially enclosed space because air can still freely flow through. However, some air could be trapped depending on the setup of the space. And then we also found that in some of the more rural areas, there are some of the clinic rooms are held in tents, and the infrastructure of the tents can also change. So I'm just figuring out how to best capture airflow with many different settings in the facilities. And we also needed to make many modifications to fit the context of patient care in Kenya and differing names for HIV services and different structures for care. So in Zambia, we saw that the ART department and TB departments were separate in the facility and had 2 different waiting room spaces and clinic rooms. However, we found that in Kenya, a lot of the care is integrated. So we needed to figure out how to capture that integrated care where different types of care would be sharing similar spaces or the same spaces. And then another challenge we encountered was leaving the CO2 monitors. We had situations where patients would tinker with it or were skeptical about the purpose of the monitor, leading to us needing to recollect some data, but also just put up signs explaining what the monitor is there for and that it's not recording audio or anything like that. And last, in many facilities in Kenya, we saw that there were designated TB days where TB patients would come to the facility to receive care, and if our data collection team wasn't there on that day, we wouldn't be able to capture data for those patients, particularly the time and motion data. So we had to rely on facility staff to self-report the service points that those patients would visit and the typical time spent at each service point, and hope that those estimations were as accurate as possible. So next I wanted to talk a bit about the model we used for the analysis. We used a modified Wells-Riley mathematical model to approximate infection risk in the clinical space. So the traditional Wells-Riley model is used in epidemiological studies to estimate the risk of infection transmission in healthcare settings. It takes into account room ventilation, airflow patterns, patient interactions, and dispersion of infectious droplets. This model typically requires advanced, expensive tools to measure in controlled environments. So we used a modification of the model that uses CO2 as a proxy measurement for airflow, which has been validated in previous studies. And since health facilities in sub-Saharan Africa typically rely on natural ventilation rather than industrial forms, its application also needed modification to fit into this setting. So we made some assumptions with the model. The first is that everyone at the facility is masked or unmasked. The number of infectious individuals in the space will be equivalent to the community prevalence. And we set the respiratory pathogen of interest for this presentation to be SARS-CoV-2 in 2022 with a community transmission level of 0.03. And our last assumption is that there's no infection risk in outdoor spaces because there would be sufficient airflow. So next, our output is a risk value ranging from 0 to 1, 0 being little to no risk, 1 being high risk. Showing the same.
I'm seeing that. Do you see it on your
Yeah.
data showing up? There we go.
Oh, cool. Okay, just a little loud. Yeah, so this output value ranges from 0, little to no risk, to 1, high risk, that indicates someone's probability of infection under these parameter conditions. And these values are calculated under 2 conditions. One, assuming everyone at the facility is masked with their mask covering their nose and mouth. This would likely occur during mask mandate periods. And then another with no masking. I want to provide some more context into the model used for this analysis. So first, the output is the probability of infection, which is that value that's ranging from 0 to 1. And the inputs to the model include a difference, okay. A difference in CO2 measurement between indoor and outdoor CO2 divided by the CO2 emission rate of a person. And we can vary the CO2 emission rate depending on the predicted state of the person. For example, this value is set to be different between patients sitting in waiting rooms silently compared to patients in clinic rooms where they'll likely be talking and emitting more CO2 or higher CO2 rates into the air. Next, we have the number of infectious individuals, which varies by community prevalence rates and can be changed to reflect different stages of an outbreak or a pandemic. Then we multiply that by the generation rate of infectious quanta for an infectious individual, which will vary by airborne infectious disease. So this is where we can plug in SARS-CoV-2, influenza, TB into the model. And then we multiply that by the pulmonary ventilation rate of a person, which reflects how much a person breathes in and out. And again, we can vary this per waiting room space and clinic room space. And last, we multiply that by exposure time and divide that by the total number of people in the room. So then in this last section, we factor in masking into the equation. So the first is the exhalation mask efficiency, which indicates how effective the mask is at preventing the infection from expelling into the air of an infectious individual. And the respiration mask efficiency indicates how effective the mask is at preventing the infection from being inhaled by an unexposed individual. So as I mentioned earlier, this AIM is an element of a larger project that seeks to determine an evidence base for the risks and benefits of high versus low HIV services during times of airborne infectious diseases for countries in sub-Saharan Africa. During my time there, conducting the pilot data collection, and from many of my colleagues who are collecting data, it's been a combined thought that, or observation, that facility staff and leadership were interested in utilizing facility level results to understand the risks to their patients and staff and inform risk mitigation. So for my master's practicum, I decided to do a side project to figure out the best way to disseminate this information to the individual facilities so that they can best understand their risks. So this ended up being a 3-page letter that will be sent out. It starts off with a cover letter that includes a brief study overview and
You try going back to the previous slide and then go back to this. Is this downloaded? Like, is this on Google Docs?
it's on Google, like the Google Slides, but it's not.
And maybe downloading it with.
Okay.
Yeah, because it just takes us.
So weird. Okay, well. Okay, there we go. So yeah, this cover letter includes a brief study overview as well as the information that they'll be able to extract from the next few pages, and a caveat that the results are predictions and should be interpreted as such. And I also included my contact information in case there was any questions or clarifications of how to best interpret the data. So the next page is an information document which details the information that we collected from the facility. an overview of the analysis for the risk calculation, and an explanation of what the risk value represents. I wanted to highlight the interpreting data and key considerations section because this is the key points that will be used to interpret the risk overview document. So I'll read through this super quick and then we'll look at the risk document and go through that together. So when looking through the results document, consider ways to reduce the risk value in spaces by considering the following. First, are there ways to increase the airflow in spaces, such as opening windows or doors to the outside? Second, can the number of people in each space be reduced, or can patients be staggered throughout the day? Third, can the amount of time patients spend in each space be reduced? And last, is it feasible for patients and providers to wear masks if supply is available? And then for some key considerations, while reviewing the data, take note of the variations in data depending on the crowding section. Use this to evaluate whether the data is representative of a crowded or slow time and how these numbers may vary depending on the time of day of the week, or month. It is also important to keep in mind that this risk value is set to a certain level of community transmission and will change when considering other respiratory infectious diseases besides SARS-CoV-2. So this is what the results page looks like. This is an example. It's all big data just so I can pull out some key points that health facility staff may be able to extract from this. So first, we have the name of the facility up top, as well as the date of the data collection and the time of the data collection. This first section is the risk overview, which is a summary of the findings by type of care. So off to the left, we have a list of the types of care that are present at that facility, the average length of visit from the time and motion part of the data collection, and then an overall risk value while masking and an overall risk value without masking. And then next we break it down by room. So we expand upon the risk overview and show the risk by room that a patient would enter. So for example, for CCC-ART, we have triage vitals, clinical room, adherence, waiting room, and then pharmacy. And we list the number of people that were in that space when the CO2 measurement was collected, as well as if the windows were open, or if there were doors and windows to the outside, and if so, if they were open. And then the average of minutes that patients spend in those spaces, and then again, the risk value masking and the risk value not masking, and repeat that for the other types of care. And then down below, we have the variations in data depending on crowding. So the first item we have is if the data was collected during reported busy hours, yes, no. Data was collected on reported busy day, yes, no. And then data was collected during a reported busy month. And these are coming directly from the facility staff self-report. So I wanted to bring our attention first to just the overall risk value, masking, no masking. And I think one of the things that stands out for me, at least when I immediately look at the results page, is seeing that there is a difference between the masking and no masking values. So a first piece of information that could be extracted from the risk profile is simply that, masking does reduce risk, and if masks are available for patients and providers, it would be ideal to use them during outbreak periods. The second, I wanted to bring attention to the triage and pharmacy room. So both of these rooms have 2 people in them. The windows and doors, it says not applicable for if they're open or shut, and the risk values are both 0.00. And these are actually outdoor spaces. Like I mentioned earlier, we have the assumption that in completely outdoor spaces, the risk would be 0. And we found that in a lot of facilities sampled, triage and vitals is done at a desk outside of the waiting room or at a desk inside of an outdoor waiting room, where that risk would be pretty low. And then pharmacies are typically windows that a patient would go up an approach to receive their medications, so they wouldn't be putting themselves at risk by entering in a physical space. And then next, I wanted to talk about the lab room. We can see that the risk value for no masking is 0.73, which is pretty high. And that the windows and doors were not open during this measurement. So consideration that could be made is to open the windows and doors to the outside during outbreak periods. And then next, I wanted to talk about the waiting room. We can see the number of people in the waiting room is 32. This is not atypical. In some smaller facilities, we see that the waiting rooms are combined with the outpatient department. So there would be many people in the waiting areas. We see that the windows and doors were open. Patients are spending a good amount of time, 10 minutes in the waiting room over the course of their visit. And again, the risk value for no masking is very, very high. So potentially a piece of information that could be extracted from this is, how can we lower the number of people that would be in that space in one time and the average number of minutes that someone would be waiting. So some considerations could be if it's a first come, first served type facility, see if during outbreak periods patients can be scheduled and have a time to stagger patients throughout the day or throughout the week. And that would reduce the number of people in the room potentially, and potentially the number of minutes as well. So next I wanted to show a real results page from one of our facilities in Kenya. So yeah, we can see, looking at the overall risk values here, we definitely see a stark difference between the masking values and the no masking values. These values are fairly low, at least in comparison to the other profile. And one thing I wanted to highlight from this risk profile is seeing the clinical rooms have the highest risk value in all the spaces, and it says the number of people in this room are 4, and it's not uncommon that there would be 2 providers and 2 patients in the room at the same time having separate conversations but sharing the space. So potentially in those types of situations, which I believe was the situation here, if possible, they would only see 1 client at a time in those spaces and limit the maximum occupancy to 2, especially because the windows are already open. And then this was taken during reported busy hours on a reported busy day, and there was no monthly variation reported. So from that, we can assume that this would be in the range of the highest values that this facility would see, because it was during the busiest period of time. All right, so next steps for our analysis is to complete the data collection in Kenya, which is expected to be completed by June 1st, and then complete the data cleaning process and incorporate the time series CO2 data to examine variation and fluctuation by day and time of day, and then run sensitivity analyses regarding crowding, seasonality, and window and door openings to determine if this risk value is likely an underestimation or overestimation of what is expected given those circumstances, and then to automate and send the risk profiles to facilities. And yeah, I just wanted to thank Monisha and Marissa Baker here for all of their help on this, and colleagues at NYU Langone Health, and then special shout out to everyone at Strathmore University that has been tirelessly collecting this data and traveling all over the country for the past 4 months for this project. And yeah, we'll open it up to any